get a cut on your hand today and the sequence is automatic. You clean it, maybe apply an antiseptic, cover it with a bandage, and within a week the skin has closed and the wound is gone. The entire process feels routine, almost boring. But strip away the antiseptic, the bandage, the clean water, the option of antibiotics if infection sets in, and what you have is a bleeding wound in a world where infection kills people with a speed and a certainty that most modern people have never had to truly confront. A world where a scratch from a thorn, a gash from a flint tool, a bite wound from prey that fought back, or the kind of deep laceration that hunting and foraging produced regularly could become septic within days and kill a fully healthy adult within a week. Early humans lived in that world every single day, and they survived. They reproduced. They built the social structures and accumulated the knowledge that eventually became civilization, which means that something was working. Something was managing wounds well enough to keep individuals alive long enough to do all of that. And the assumption that early humans simply suffered, bled, got infected, and died at the first serious injury turns out to be as wrong as almost every other assumption people carry about prehistoric life. The story of how early humans healed wounds without modern medicine is not a story of helpless people enduring the consequences of ignorance. It is a story of accumulated, transmitted, sophisticated knowledge about the properties of plants, minerals, and biological materials that in many cases anticipated, by thousands of years, the same chemical mechanisms that modern pharmaceutical science eventually identified, isolated, and patented. It is a story of bodies that were, in some respects, better adapted to managing injury than modern bodies living in sterile environments, and it contains at least two specific discoveries from the archaeological and anthropological record that will genuinely shock you, not because they suggest that ancient wound care was as good as modern medicine, but because they demonstrate that it was so much better than nothing, that the gap between prehistoric wound management and modern emergency medicine is significantly smaller than most people assume. Stay with me, because the history of wound healing before antibiotics and sterile dressings is one of the most practically fascinating and most consistently underestimated chapters in all of human prehistory. Let's start with the body itself, because the first wound healing system available to early humans was not a plant or a mineral or a technique. It was the immune system and the cascade of biological processes. The body deploys automatically in response to tissue damage. And understanding this baseline is important because it reframes what ancient wound care was actually trying to do. When tissue is damaged, the body's wound healing response activates in a sequence so precisely organized and so biologically sophisticated that researchers studying it today still haven't fully mapped every element of its molecular signaling. The immediate response is hemostasis, the arrest of bleeding through vasoconstriction, platelet aggregation, and the formation of a fibrin clot. This happens within minutes. It happens without any external intervention, and it happens reliably enough that most wounds, if not too large or located over major vessels, stop bleeding on their own given time. The clot that forms is not just a plug, it is a temporary scaffold that provides structure for the tissue repair process that follows. The next phase is inflammation. The phase that looks and feels most like a problem because it is painful, hot, swollen, and red, but is in fact the immune system deploying exactly the resources the wound needs. White blood cells flood the wound site. Macrophages consume debris and bacteria. Growth factors signal surrounding cells to begin multiplying. The inflammatory response is self-limiting under normal conditions, and the tissue remodeling phase that follows gradually replaces temporary repair material with structured new tissue. The entire process, for a wound of moderate size in a healthy individual, does not require any external intervention to complete successfully. The body is running a wound healing program that predates human consciousness by hundreds of millions of years. What external intervention actually does, whether ancient or modern, is support this process and protect against its primary point of failure. The fibrin clot that arrests bleeding is an excellent temporary solution for the first phase of healing, but it is also a hospitable environment for bacterial growth. The warm, protein-rich, partially oxygen-depleted interior of a wound is approximately optimal growing conditions for the bacteria that exist on skin surfaces and in the environment. The difference between a wound that heals and a wound that kills is almost always whether bacterial colonization of the wound site reaches a level that overwhelms the immune response. Everything that works in wound care, ancient or modern, works by either suppressing bacterial growth, supporting the immune response, or both. Ancient humans did not know about bacteria. The germ theory of disease was not articulated until the 1860s. But they did not need to understand the mechanism to understand the outcome. Accumulated empirical observation across thousands of years and millions of individual wound healing experiences produced a body of practical knowledge about which interventions reliably produced better outcomes and which reliably produced worse ones. The knowledge of what worked was transmitted across generations long before anyone had a theoretical framework for why it worked. Now, here is where this story starts doing something genuinely unexpected. Because the plants and materials that early humans used for wound care were not random. They were not superstition or placebo. When modern pharmacological research has tested the specific plants documented in traditional wound care practices from cultures around the world, the results have been consistent enough to constitute one of the most striking patterns in all of ethnobotany. The plants that traditional cultures used for wounds work. In many cases, they work through mechanisms that modern science has now specifically identified, mechanisms that were operating every time an ancient healer applied them, understood or not. Honey is perhaps the most thoroughly researched example, and the research results are dramatic enough that they have produced a genuine reintegration of honey into modern clinical wound management. Archaeological evidence of honey use in wound treatment appears in ancient Egyptian medical papyri dated to around 1550 BCE, in ancient Greek medical texts, in Vedic texts from ancient India, and in the traditional medical practices of indigenous cultures on every inhabited continent. Every major ancient medical tradition that has been studied used honey for wound treatment. This universal convergence is itself significant because it represents the same empirical conclusion reached independently by unconnected cultures around the world across thousands of years of practical observation. Modern research has now identified exactly why honey works, and the mechanisms are multiple, overlapping, and genuinely impressive. Honey has a water activity, the measure of available water in a substance, so low that most bacteria cannot grow in it. Its high sugar concentration draws water out of bacterial cells through osmosis, effectively dehydrating and killing them. It produces hydrogen peroxide through the action of the enzyme glucose oxidase. It contains B-defensin 1, an antimicrobial peptide. It has a pH of approximately 3.5, sufficiently acidic to inhibit most bacterial growth. Manuka honey specifically, from bees foraging on manuka trees in New Zealand, contains additional methylglyoxal compounds with potent antimicrobial activity against organisms including MRSA, the antibiotic-resistant staph infection that kills tens of thousands of people in hospital settings every year. Ancient wound healers using honey were applying a multi-mechanism antimicrobial agent of genuine clinical efficacy. They were doing this without any understanding of bacteria, without any concept of antimicrobial activity, without the theoretical framework that would have let them explain why it worked. They were doing it because accumulated empirical observation had established that wounds treated with honey healed more reliably than wounds that were not. The pharmacology was real and operating long before anyone could describe it in pharmacological terms. Stay focused here, because honey is just the beginning of this catalog, and what comes next in the plant pharmacology of ancient wound care is even more striking. Willow bark has been used in traditional wound care and pain management across cultures for thousands of years. The active compound responsible for its effects, salicylic acid, is the direct chemical precursor to aspirin. Aspirin was synthesized in 1897, but the compound it is derived from was being applied to wounds and consumed for pain relief for at least 3,000 years before that, in traditional practices whose practitioners had no knowledge of its chemical identity. The willow bark applications worked because salicylic acid is both anti-inflammatory and mildly antimicrobial. Ancient healers using it were suppressing the excessive inflammation that can interfere with normal wound healing and simultaneously providing some bacterial inhibition through a compound they did not know existed, because experience told them the treatment worked. Garlic, which appears in wound treatment protocols in ancient Egyptian, Greek, Chinese, and Indian traditional medicine, contains allicin, a sulfur compound with documented broad-spectrum antimicrobial activity. Laboratory testing of allicin against wound-infecting bacteria, including Staphylococcus aureus and Streptococcus pyogenes, has confirmed genuine inhibitory activity at concentrations achievable through topical application. Ancient healers applying crushed garlic to wounds were introducing a compound with real antimicrobial properties. The mechanism was completely invisible to them. The outcome was not. Turmeric, documented in traditional Indian and Southeast Asian wound care practices across thousands of years, contains curcumin, a compound with anti-inflammatory, antimicrobial, and wound healing promoting properties that have been confirmed in modern research extensive enough to have produced hundreds of published pharmacological studies. Its traditional application to wounds in the form of a paste was not superstition. It was the delivery of an active wound healing compound to a wound site in a formulation practical for the application context. Clay and mineral earths applied to wounds appear in ancient Egyptian and Greek medical texts and in traditional practices globally. Certain clay minerals, particularly those containing kaolin, bentonite, and smectite, have documented antimicrobial properties through ion exchange mechanisms that draw bacterial toxins and bacteria themselves into the clay structure. The use of specific mineral earths for wound treatment by ancient practitioners who selected particular types of earth from particular locations, rather than applying any available soil, represents the same empirical convergence on real pharmacological activity that appears throughout this history. Now here is the moment in this story I need you to pay attention to most closely, because what comes next is the discovery I promised at the beginning, and it goes further back in time and reaches further into the question of human intelligence than most people are prepared for. In 2012, researchers excavating a burial site at Shanidar Cave in northern Iraq, a site that had been producing significant discoveries since the 1950s, recovered skeletal remains alongside something that had been placed deliberately in the grave. What they found, when they analyzed the floral material associated with the burial, was a cluster of plant species, with no obvious food value at the burial site, but with well-documented medicinal properties in traditional healing systems. Ephedra, a plant containing ephedrine with documented bronchodilator and circulatory effects. Yarrow, with confirmed wound healing and antimicrobial properties. Groundsel, used in traditional wound care across multiple cultures. The burial was dated to approximately 60,000 years ago, and the individual buried was a Neanderthal. The interpretation of the Shanidar flower burial has been debated since Ralph Selecki first published it in 1975, and the debate has not fully resolved. Some researchers have raised the possibility that the plant material was introduced by animal burrowing rather than deliberate placement. But the specific combination of medicinally relevant plants, the pattern of their distribution around the skeletal remains, and the broader context of Neanderthal behavior documented at Shanidar and other sites have led many researchers to maintain that the deliberate placement interpretation remains the most compelling explanation of the available evidence. If correct, what this means is extraordinary. 60,000 years ago, Neanderthals, a species that was not our own, but whose cognitive and behavioral capacities have been dramatically upgraded by recent archaeological research, were not just using medicinal plants for their own care. They were placing medicinal plants with the dead in a pattern consistent with knowing which plants had healing properties and attributing significance to that knowledge, significant enough to mark a death with it. The knowledge of wound-healing plants was old enough, established enough, and culturally significant enough to be incorporated into mortuary ritual 60,000 years before the Common Era. But the evidence for ancient wound care does not stop at plants and minerals. Some of the most striking discoveries in this field concern the physical procedures that ancient humans performed on wounds and the skill and sophistication with which they performed them. Archaeological evidence of prehistoric surgical procedures is both more extensive and more technically impressive than most people expect. Skulls showing evidence of trepanation, the deliberate cutting of holes through the skull, have been found across multiple continents and span a date range from approximately 10,000 years ago up through historical periods. What is significant about the trepanation evidence is not just that the procedures were performed, but that the skeletal remains show evidence of healing around the cut edges, indicating that patients survived the procedure and lived long enough for significant bone regrowth to occur. Survival rates for prehistoric trepanation, assessed from the proportion of skulls showing post-operative bone healing, appear to have been genuinely substantial in some periods and locations, comparable in some studies to pre-antiseptic era surgical survival rates in 19th century hospital settings. The tools used in these procedures, obsidian blades in many contexts, are relevant here because obsidian fractures to a cutting edge at the molecular level, producing blades sharper than modern surgical steel. Researchers who have compared obsidian surgical tools to modern steel scalpels have found that obsidian produces a finer, cleaner cut with less tissue trauma on microscopic examination. The ancient surgeons using obsidian were not working with crude or inadequate cutting tools. They were working with the sharpest cutting instruments available anywhere on Earth until the development of modern metalworking produced tools that could approach equivalent sharpness through different means. The bone evidence also shows examples of amputations that healed, limbs missing below a joint with healed bone ends, indicating that the individual survived the amputation and the subsequent healing process. Spinal injuries with extensive bone remodeling suggesting long survival after injury. Healed fractures indicating effective immobilization. The people performing wound and injury management in prehistoric communities were achieving outcomes that should not be achievable without the pharmacological and technical resources modern medicine takes for granted. And the archaeological record documents those outcomes in the most unambiguous possible evidence. Healed bone belonging to individuals who lived through what should have been unsurvivable injuries. Here is the final layer of this story, and it is the one that connects the ancient wound healing knowledge most directly to what is happening in modern medicine right now. The 20th century confidence that modern pharmaceutical medicine had essentially solved the infection problem is being progressively eroded by the development of antibiotic-resistant bacterial strains. MRSA, difficile, drug-resistant tuberculosis, and a growing roster of organisms that no longer respond to available antibiotics are creating a genuine crisis in modern wound and infection management. Hospital-acquired infections kill more people in developed countries every year than many of the conditions those hospitals are treating. The pharmaceutical pipeline for new antibiotics has been largely dry for decades because the economics of antibiotic development do not incentivize the required investment. Into this crisis, researchers have turned back to the ancient pharmacopoeia with new eyes and new analytical tools. The compounds in honey that work against MRSA, the allicin in garlic that shows activity against drug-resistant staph, the silver nanoparticles found effective against biofilm-forming bacteria, silver having been used in wound dressings in various forms for centuries before modern understanding of its mechanism. Clay minerals with ion exchange antimicrobial activity being investigated for clinical application to antibiotic-resistant wound infections. The maggot therapy, the deliberate application of sterile fly larvae to necrotic wounds, that was standard wound care in many traditional contexts and is now a licensed medical procedure in multiple countries, because controlled research confirmed what traditional practitioners had known empirically for centuries. Maggots debride necrotic tissue and secrete antimicrobial compounds that promote healing in wounds that resist conventional treatment. The ancient wound healing knowledge that mainstream medicine dismissed as primitive superstition for most of the 20th century is being systematically re-examined and in case after case confirmed as containing genuine pharmacological activity. Not all of it. Not every traditional remedy or practice, but enough of it, consistently enough, that the pattern has become impossible to dismiss. People who had no germ theory, no microscopes, no controlled trials, no pharmacology, accumulated through the most direct and costly kind of empirical research, the observation of who lived and who died and what had been done for each of them, a body of wound care knowledge that contained real, effective, pharmacologically active treatments. They did not know why it worked. They knew that it did. And the people who benefited from that knowledge, the hunter-gatherer with a deep gash who survived because someone applied honey and yarrow and kept the wound covered, the prehistoric surgical patient whose trepanned skull healed enough to leave clear bone growth around the cut edge, the ancient amputee whose stump healed cleanly enough to leave no evidence of the infection that should have killed them, all of those people lived because accumulated human intelligence, transmitted across generations without writing, without schools, without any of the formal structures we associate with knowledge, was real, was effective. Was medicine in every meaningful sense of the word, just medicine that operated for thousands of years before anyone knew what medicine actually was. The wound you get today that you clean and cover and forget about in a week is being healed by the same biological cascade that healed wounds for 300,000 years. The difference is that you have support systems for that process that are more reliable, more consistent, and more effective in the worst cases than anything ancient people had access to. But the ancient people were not helpless. They were not simply surviving despite their wounds and hoping for the best. They were applying real knowledge, encoding real pharmacological effects, performing real clinical procedures with tools and techniques that archaeology continues to reveal as more sophisticated than the comfortable assumption of primitive helplessness ever allowed room for. They healed wounds. With what they had, in the world they lived in, with knowledge accumulated over thousands of years of watching human bodies fight, and sometimes lose the same fight, your immune system has been fighting your entire life without you ever having to think about it. The scratch on your hand heals in a week. Theirs healed too, just with honey instead of neosporin, with yarrow instead of ibuprofen, with obsidian instead of steel. With the same body, doing the same thing it has always done, given just enough support from people who had been paying very close attention for a very long time.